blocks. So super helpful, I think, throughout the Pacific, not only just for intraoperative analgesia or anesthesia, but also for post-operative analgesia. So the nerve blocks that I'll focus on today are ones that can be identified with the PEARLS probe, the butterfly probe. So I'm going to cover 4 main nerve blocks today. So the sciatic nerve block with the popliteal approach. We'll also have a chat about the adductor canal encephalous nerve block, the femoral nerve block, and then we'll finish with the fascia iliaca block and discuss both the supra and the infra inguinal approaches. So first up is the sciatic nerve block with the popliteal approach. So with the sciatic nerve block, it's responsible for the majority of sensation and motor function, particularly below the knee. So you can see highlighted in the green here will be the sciatic nerve innervation, the sensory innervation. So if we need analgesia below the level of the knee, we're going to cover all of that section. The strip that's uncovered there is covered by the saphenous nerve, which we'll cover later, but it's a very handy block to know. I won't chat too much about the anatomy today. I think a lot of that can be read online and discussed discussed in the textbook. So I'll just cover it briefly. But the most important part clinically is that the sciatic nerve is actually comprised of 2 major nerves, as you can see here. So the tibial portion, or the posterior tibial nerve, and then the common fibula, or the common peroneal portion. So always think of them as 2 nerves, and that becomes very important. It's the thickest nerve in the body, and so that's also handy to know because it's got the thickest neural sheath. So it can take quite a while for a local anesthetic to diffuse across to the nerve and take effect. It starts up high up in the buttock region and descends down, and you can see here it is comprised of 2 nerves, and then just above the popliteal fossa, it bifurcates here and continues to the posterior tibial and the common peroneal. That bifurcation varies between patients, but in the majority of patients, it bifurcates about 10 centimeters above the popliteal fossa. This is also handy to know that the sciatic nerve can be blocked at any stage along its course. So it can be blocked in a transgluteal approach. It does become a little bit riskier as it becomes a deeper block there. So you need to give a little bit more consideration to anticoagulation and things like that. And the most commonly blocked region is the popliteal approach. So that's what we'll chat about today. So this is, again, the point that I'm going to reinforce is that it comprises 2 nerves, and it's super important. So as you can see within this, it's called Bloch's sheath, which is the sheath that comprises both the tibial nerve and the common peroneal or common fibular nerve. And we'll be able to see that in ultrasound. With the sciatic nerve block, for a successful nerve block, you need to be within this sheath. Otherwise, it's going to lead to block failure. Like I said before, it is the thickest nerve and sheath in the body. So if our local anesthetic is outside of the sheath, it will not diffuse across into that within that sheath and take effect. So it's really important to be within the sheath. And one of our endpoints of a successful block will be we call it an hourglass or a figure of 8 distribution of local anesthetic around those two nerves, and I'll have examples shortly. So hopefully these images come up okay. This is an ultrasound image of the sciatic nerve and the popliteal approach. So when we put the ultrasound probe in the popliteal fossa, what we'll see is the popliteal artery with the vein just above it. And then above that, we'll see the sciatic nerve. So it is usually relatively superficial at this level. either side of this, we see the hamstring tendon, so the semimembranosus and the biceps femoris. And then we see these two nerve components, so the tibial nerve and common peroneal nerve. And it's really important to find where that bifurcation is. It's not labeled on this image, but the left of the screen will be the lateral approach. And we know that because the common peroneal will be lateral. And that's like, we know that because what we sometimes see is when patients have accidents or car accidents, or they get hit on the leg by a car from the lateral component, they can end up with a foot drop, and that's usually due to the exposed common peroneal nerve on the lateral component near the fibular head. So it's really important because our approach for this nerve block is from the lateral approach. So there is a risk of damaging that common peroneal nerve if we don't identify it first. This is another example. You can see the tibial nerve, and hopefully you can start to make out that it actually comprises two nerves there. And again, we've got the popliteal artery, the popliteal vein, and on top of that, we can see the large posterior tibial nerve, and then a little bit lateral to it, you can see the smaller common peroneal nerve. This is the most convenient approach if you're able to position the patient like this. So you just have them lying on their side. If you do have the option of a pillow or some sort of support between the knees, just for comfort, that would be ideal. And then ergonomically, you'd want to be on on the side of the patient and having the ultrasound screen. If you've got the butterfly probe either on the same side or positioned somewhere so you're nice, you're positioned quite ergonomically, and this allows a nice lateral access or lateral approach to the nerve. You can see the popliteal fossa, so it would start scanning about 10 centimeters above that popliteal crease, looking for the bifurcation. And I've got a video here, and hopefully the audio comes through as well. It'll go for a couple of minutes.
Excuse me, Luke. Could you speak over the video because we couldn't actually hear the audio. So if there were some important parts, could you just speak over it?
Yeah, sure.
Great, thanks, Luke.
Alrighty, so what's important here is we're doing some dynamic scanning. So scanning the probe proximally and distally, and we're trying to identify that common peroneal nerve where it joins the posterior tibial component. So that's the most important aspect to identify. I wouldn't perform this block if you can't identify those two nerves, particularly the common peroneal. Our approach comes from the lateral position, and because it does come from the lateral position, it's one of the risks is that we can transect the common peroneal nerve if we don't identify it early. So I wouldn't perform this block unless you can accurately identify the common peroneal. Our needle here is aiming for, we're going to be aiming for the fatty tissue between the two nerves. So that's our sort of zone of safety, and that fascia can be quite thick, so it can indent quite a bit before you feel the tactile pop through the sheath. Once you're through the sheath, you just give a small test injection, which should be low pressure, and we should see that hourglass spread or that figure of 8 spread around the two nerves. So you can see with this initial injection here, the local anesthetic is still outside that thick sheath. So you can see it start to spread outside the sheath, which is not where we want it. So what we're going to do here is advance the needle ever so slightly more, and you'll see that a little bit of a give as it passes through the sheath just there. And then again, we'll repeat that step. We'll just give another mil or two of local anesthetic, and you start to see it spread in that figure of 8 or hourglass distribution, which is an excellent endpoint. That's the endpoint that we're aiming for a successful nerve block. In this video, they say to put 20 to 30 mils of local anesthetic in. In reality, you only need about 15 mils. And depending on what you're after, if you're after surgical anesthesia, you'd use a higher percentage, so like 0.75% ropivacaine or something like that. Or if you're just after some analgesia for post-operative effect, you can use 0.2%. I'll just make sure we saw everything on that video. You can see as we start to infiltrate, you can see the posterior tibial nerve is completely encircled by local anesthetic, and the common perineal is starting to be distributed as well. So there's the posterior tibial, there's the posterior tibial nerve and the common perineal nerve. That's pretty much it. All right, so the biggest tips for the sciatic nerve block. The first one will be fanning or tilting the probe to really highlight the nerve structures. So you really want to get that ultrasound beam perpendicular with the sciatic nerve. And so this is just going to be a bit of trial and error. So whenever you think you've got an okay view of the nerve, just tilt it ever so slightly towards the head or towards the feet, and really try and make that nerve stand out. So that'll be a huge step in favor of success. The second pearl would be always find that common perineal nerve. So there's always case reports of permanent foot drop from a transected common perineal nerve. So really don't perform this block unless you identify both. And just keep in mind that bifurcation of the nerves usually occurs about 10 centimeters proximal to the popliteal crease. So it can be quite high in some patients. This is one of the blocks that I'd normally do awake. There's a lot of blocks that we can do asleep, particularly if we don't need to get too close to the nerve. So, blocks like your tap blocks or your rectus sheath blocks or even your saphenous nerve block, you can do with the patient asleep. And to reduce the risk of nerve injury, the sciatic nerve block is one that I would do with the patient awake. The third pearl would be looking for that nice endpoint, which is the hourglass or the figure of 8 spread of local anesthetic around the nerve. Just keeping in mind that Blocher's nerve sheath is quite thick, and you do need to be within it in order for a successful nerve block. We said before that the nerve sheath is quite thick, and it does take a while for that local anesthetic to diffuse. For surgical anesthesia, it can take up to about 40 minutes for complete effect. So in a busy emergency department or a busy list, you don't always have time for that. So just keep that in mind as well. But there's still huge benefits for post-operative analgesia. The other thing to keep in mind is that if you're using this block in combination with a saphenous nerve block for a foot procedure, a popliteal sciatic nerve approach won't cover may not cover the tourniquet if it's placed on the thigh. So that's another thing to keep in mind. And ways you can get around that is either just checking in with the patient and providing reassurance, or it may need a little bit of sedation just to help the tourniquet discomfort if the surgeons aren't able to put the tourniquet on the calf. Alrighty, so that's the popliteal approach to the sciatic nerve block. What we'll chat about next is the adductor canal block. So I've sort of grouped these together: the adductor canal block, the saphenous nerve block, the subsartorial block, all more or less similar. So the adductor canal block will target the saphenous nerve, and that saphenous nerve is it's the only non-sciatic sensory component below the knee. So if you want complete anesthesia below the knee for a surgical approach, then this will need to be combined with your sciatic nerve for a successful block. The saphenous nerve is the only sensory nerve of the femoral nerve below the knee. So this is the image that I showed before. So this area in green is the sciatic nerve distribution, and the strip that isn't green, that'll be the saphenous nerve. So as you can see, it's mainly skin innervation, and it's over the medial malleolus and that medial calf. The saphenous nerve is a branch of the femoral nerve. So as you can see, and it can be blocked at any stage. So if it's blocked sort of in that middle third of the thigh, we call that the adductor canal block. As it moves towards the distal third of the thigh, we call that the subsartorial or saphenous nerve block. And as you can see, it can also be blocked down, and this can be done by a landmark technique or by the surgeons as well. So just in that medial proximal tibial, that can be done by a subcutaneous wheel. So we normally do it in this distal third region. So it's mainly skinned that lower leg, and also provides some infrapatellar anesthesia for the knee joint as well. So this is an image of the adductor canal. So this is the sartorius muscle. So what we're looking for when we put the ultrasound probe on is this boat-shaped or trapezoid-shaped sartorius muscle with the femoral artery below it at roughly the 6 o'clock position. Within that adductor canal, we've also got the femoral vein deep to the femoral artery, and then laterally, we've also got the sartorius nerve. So you don't necessarily need to be adjacent to the saphenous nerve. As long as you're within that canal, you'll get a successful block. And so you won't always see the saphenous nerve. After you start to inject the local anesthetic, we should start to see a structure that resembles the saphenous nerve, and we should also see some spread across to that contralateral side of the femoral artery. And we'll show that shortly in an example. The other thing to keep in mind with this block, within the adductor canal, there's also the NVM, the nerve to vastus medialis, and there's a little bit of growing evidence that both nerves can or should be blocked. The nerve to vastus medialis is a little bit smaller than the saphenous nerve, and so it can be transected accidentally. With the butterfly probe, you may not always see the nerve to vastus medialis, so we'll just be aware that it is located a little bit more laterally below that subsartorial fascial layer. We normally aim for that middle, middle to distal third. The risk of doing the adductor canal block a little bit higher is that we can get local anesthetic spread proximally, and then we can start to get more of the femoral nerve blocked, and that can lead to quadriceps weakness, which can lead to falls and things like that if the patient's mobilizing after this block. If it's done in that distal third, it should just be a purely sensory block. So the patient should still be able to mobilize immediately after surgery if the surgeons are happy as well. So as you can see here, we've got that boat-shaped sartorius muscle, the femoral artery at the 6 o'clock position, And then we've got the femoral vein deep. And then below this sartorius fascia, we've got the saphenous nerve. So our aim is to just get our needle tip below the sartorius muscle, whether we do it laterally or whether we do it just top of the artery. It's up to whatever the images, the best images are. This would be our usual position. So we call it frog legging, where the patient's supine, and then we just slightly bend the knee to 45 degrees and then externally rotate it. That's the frog leg position. The ultrasound probe will start either to the middle to distal third of the thigh, and we just want to see that femoral artery below the sartorius at about the 6 o'clock position. And here's a video for a few minutes. I'll talk through it because I don't think the sound's coming through.
No sound coming through, Luke.
Oh, I'll just double check. Is that sound coming through or?
No, Luke, sound's not coming through.
Okay, cool.
Yeah.
All right, so you can see here we've got the nice image of that boat-shaped sartorius, the femoral artery at the 6 o'clock position. So this is exactly where we want to be. The femoral vein is a little bit deeper, and then laterally, you can't always see it, but you should be able to have a rough idea of where the sartorius nerve is. And then you've got both. You've got the vastus medialis and the ductus longus, either side of the adductor canal. So you have to use your eye of faith a little bit to appreciate the saphenous nerve, but visualizing the nerve isn't super important. You really want to get a really nice view of this sartorius fascia and use both visual and tactile feel to appreciate when your needle tip is below or has pierced that sartorius fascia. So we're coming in from the lateral position. It doesn't matter whether you go through the sartorius muscle or along the fascia. So in this approach, as you can see, one of the risks is either transecting the sartorius nerve or an arterial injection. So it's super important to watch your needle tip at all times, and also to appreciate the tactile feel of the sartorius muscle. So I'm sure a lot of you rely on that tactile feel for, you may do a lot of like either blind tap blocks or landmark techniques for the fascia iliaca block. So it's very similar, just relying upon that tactile feel. You can see as we start to inject that local anesthetic, what we're looking for is a nice smooth spread around the saphenous nerve, but also to that contralateral side of the femoral artery. So that's a sign that we are within the adductor canal. So you can see that spread to the contralateral side of the femoral artery. And then as we scan a little bit more proximally and distally, we should be able to appreciate the saphenous nerve, which is starting to look like it's this structure just over here. So you can see that saphenous nerve being enveloped by local anesthetic. For this block, again, if you're after surgical anesthesia, be using 0.75% of ropivacaine, even 0.5% of bupivacaine, which I know is very readily available throughout the Pacific. And then if you're just after analgesia, again, 0.2% and using about 20 mils of local anesthetic. The key endpoint is if you can see the saphenous nerve after the injection enveloped by local anesthetic, that's perfect. So the pearls for the adductor canal block is positioning the patient, so getting them in that frog leg position, so bending the knee at 45 degrees and then externally rotating, and aiming for that middle to distal third. Aim to have that femoral artery at the 6 o'clock position, so directly underneath the sartorius muscle. And always be aware of the nerve to vastus medialis. It is difficult to see, but it has been an issue in the past where it has been accidentally transected, and that can lead to medial quadriceps weakening over time. So, and the way to avoid that is by, I think, going through the sartorius muscle at a relatively steeper angle if you can't appreciate the nerve to vastus medialis on the scanning. Alrighty, so those two blocks will completely anesthetize the leg below the knee. So now we'll chat about the femoral nerve and the fascia iliaca block. So we're moving a little bit more proximally up towards the hip. So the femoral nerve block, this is the distribution of analgesia or anesthesia that we'll achieve with the femoral nerve block. As you can see, there's that saphenous nerve component below the knee, and then the proximal portion as well. So note that this will obviously cause quadriceps weakening, and the patient won't be able to mobilize after a femoral nerve block. It is often used in hip fractures and things like that. But the hip joint is, as you're aware, that it's quite difficult to block or analgese completely without the use of a spinal anaesthetic, just because we've got to block both the femoral nerve, the lateral femoral cutaneous, also the obturator, and then a portion of the sciatic. So we won't get complete analgesia of the hip with a femoral nerve block, but we can definitely assist with analgesia. So the femoral nerve block is lies in the proximal thigh, underneath two fascia layers. So we've got the fascia lata and the fascia iliaca, and then it's so sort of that old med school teaching of nerve, artery, vein. The femoral nerve is enveloped by the fascia iliaca, and it's important that we get within that fascia iliaca sheath in order to get a successful femoral nerve block. So these are a couple of still images. The important thing for this image, so as you can see, the image on the right here is the femoral nerve is a lot easier to see next to the femoral artery. The image on the left here, you can see both the femoral artery and also the deep artery of the thigh. And this is also a common image to see once we start scanning. Ideally, what we want to do is just, if we get this image, we just want to scan a little bit more proximally back towards the inguinal ligament or inguinal crease. And we ideally want to get this image where this image on the right, where the deep artery of the thigh has disappeared or essentially joined the femoral artery. So we just want to see the femoral artery with the femoral nerve, the triangular shaped femoral nerve lateral to it. So if we ever get this image on the left, just scan a little bit more proximally, and your view will improve. Our approach for this one, we just got the ultrasound probe in the quite proximally, close to the inguinal crease, inguinal ligament, and our approach is going to be from a lateral to medial approach. So with this video here, what we can see is the femoral artery is quite obvious. So just lateral to that is this triangular femoral nerve, and that's going to be enveloped by the fascia iliaca fascia. And so what we want to do with our needle coming in from the lateral position is just get within that fascial sheath. And then a good endpoint for the femoral nerve block is that we should see that nerve being pushed away by our local anesthetic. So we should be able to appreciate that in the video here as we start to inject. You can see the tip of our needle just next to the femoral nerve. And as we inject, we're seeing that femoral nerve being pushed away, which is a really nice endpoint. And again, as you start to inject the local anesthetic, you should start to appreciate the nerve structures a lot better with that nerve fluid interface. And again, using a combination of ultrasound and tactile feel, we'll go a long way to a successful block. So you can see that local anesthetic is going to completely envelope this nerve, which is perfect. So here, because they've enveloped the femoral nerve quite well, with just 8 mils of local anesthetic, that's all they need. In if the images aren't quite as nice as that, or you don't get that nice enveloping, I'd still use upwards of 20 mils of local anesthetic. Again, with those concentrations that we've mentioned. For the femoral nerve block, so the two pearls would be scanned proximally. So make sure that if you're seeing the deep artery of the thigh, just scan more proximally to make sure that that deep artery of the thigh and the femoral artery join and disappear and just become the one femoral artery, and that'll improve your view. And an excellent endpoint is that the local anesthetic should displace the femoral nerve immediately on injection. And so lastly, we will finish up talking about the fascia iliaca block. So there's two approaches for this. There's the infrainguinal and the suprainguinal. So using the inguinal ligament as a landmark. So we're either going infra or below the inguinal ligament, which is essentially just like a lateral femoral nerve block. Or we can do the suprainguinal approach, which we'll talk about the anatomy shortly, but there's a few things we need to watch out for just to reduce our risk of complications. And for this, sort of about personal preference and also the indication for the block. If you're doing it for a proximal hip fracture, my preference for this is the suprainguinal approach. The idea being that you can use quite high volume and you're more likely to block that obturator nerve, which can be quite tricky to block with the infrainguinal approach. But I'll have a chat about both of them. So I'm sure a lot of people have done the landmark approach for the fascia iliaca block, and for this block, when we use the butterfly probe or an ultrasound probe, I'd always recommend using a combination of that tactile feel that you're so proficient at, as well as the ultrasound visual component and use them both in combination for a successful block. So for our landmark here, we're using the ASIS and the pubic tubercle. If we divide that up into thirds, and we're going to use the lateral third and then just go a centimeter lower, and that's going to be our entry point for the landmark technique. And that's more or less going to be very similar to the orientation for the fascia iliaca block. The nerve distribution will be very similar to that femoral nerve block, except we're also getting a little bit more of the lateral thigh here, so by the lateral femoral cutaneous nerve, and also a little bit of obturator nerve coverage as well for that proximal hip joint. So for the infrainguinal approach, very similar. Just think of it like a lateral femoral nerve block. So positioning is exactly the same. We find that femoral nerve, we just slide our ultrasound probe a little bit more laterally, and this is a high volume block. So I'd normally use upwards of 30 to 40 mils of local anesthetic, and using your 0.5% ropivacaine or bupivacaine, or a little bit less is okay here, just because we're going higher volumes, so 30 to 40 mils. And the aim is that we're getting this spread below the fascia lata, below the fascia iliaca, and we're getting spread on top of the femoral nerve and also out laterally towards the sartorius muscle to get the lateral femoral cutaneous nerve as well. So you can see here, very similar to our femoral nerve block anatomy. So you can see the femoral nerve here. Laterally, we see this fascia iliaca fascia layer very nicely on the ultrasound image here. And the idea is that we'll just come in laterally with our needle, pop below that fascia lata here, pop below the fascia iliaca here. So that's our 2-pop technique. And then we're just spreading local anesthetic below the fascia iliaca here. And we'll see spread medially and also see spread laterally towards the lateral femoral cutaneous nerve. Alrighty, so with the suprainguinal approach, what we do differently is the nerve or the image that we had with our infrainguinal approach. We're just going to turn the ultrasound probe, rotate it 90 degrees. So as you can see, this is the patient's leg on the left here, and then we're moving up towards the trunk or cephalad here. So we try and have that ultrasound probe positioned again in that lateral third, like you would in the landmark technique, and we'll try and have the middle of the probe cross the inguinal ligament, and have the cephalad portion of the ultrasound probe pointing towards the umbilicus. And so the image that we see here, people talk about the bow tie appearance. So to the left of the screen, we're seeing the what's cephalad or towards the head, and we're seeing the internal oblique muscle form a bit of a triangular shape here, and then it thins out, so the thin portion of a bow tie, and then you can see another triangular muscle here, which is the sartorius muscle, and so hence the bow tie or the hourglass appearance for the suprainguinal approach. And so what we're trying to do with our ultrasound image initially is we're trying to see the pelvic brim, this white structure in the middle of the probe. On top of that, we're going to have the iliopsoas muscle, and then we're looking for the bow tie. The important structures to identify here are some of the deep abdominal structures below the internal oblique muscle. So it's really important that we identify those as to avoid them. Obviously, the risk with the suprainguinal approach is that of either these deep arteries to be punctured, but also we've got bowel and peritoneum deep to that also. So again, what we can see here is this bow tie appearance of the sartorius muscle leading up to the internal oblique. We can see the vessels on the left side of the screen. And what we're aiming to do here, it's still a very superficial block, so we'll only be like 1 or 2 centimeters deep on average. And we're just aiming to get below the fascia and on top of the iliopsoas muscle. And again, high volume block, 30 mils, and we want to see spread on top of that iliopsoas muscle. Again, just reinforcing the bow tie appearance that we'll be aiming for. So we've got that fascia iliaca, the thin part at in the middle, with the two triangular shaped muscles. So the internal oblique muscle on the left, and then the sartorius muscle inferiorly. You can see the vessels on the left side of the screen, the deep epigastric vessels, quite obviously there on the left side of the screen. So this is this is our ultrasound image that we'll be aiming for initially. So we'll have that ultrasound probe on that distal or lateral third of the inguinal ligament, pointing towards the umbilicus. And what we should ideally see on our initial imaging is that pelvic brim in the middle of the screen, and on top of that, we should see the iliacus or iliopsoas muscle. And then we're looking for that bow tie appearance. So we can see the deep circumflex iliac arteries. And so this will be the triangular shaped internal oblique muscle on top of those. Thins out to the fascia, and then we'll see the triangular shaped sartorius muscle caudad. So as you can see here, with our needle coming in from caudad, we're just aiming to get below those 2 fascias. So again, you use your tactile technique. Be sure to avoid the peritoneum, avoid these deep circumflex vessels, And we want to see a nice endpoint, which is spread on top of that internal oblique muscle, sorry, on top of the iliopsoas muscle. So you can see here the spread is still intramuscular. So we're not getting that nice unzippering effect, it's called, where you get a nice spread with minimal volume along the muscle. So we're just going to readjust our needle tip here. So we're still not in the right plane. So we're going to come back out with our needle and reinsert, keep an eye on that needle tip at all times. Appreciate the tactile pop. So you can see the pop just there. And now we'll try again. A little bit of volume. And you can see that spread. It really like just peels off or unzippers. So that's a really nice endpoint that we're looking for. And so this is where we use our 30 to 40 mils of local anesthetic. And the idea of this superinguinal approach is that we start to block the obturator nerve, as well as the femoral nerve, as well as the lateral femoral cutaneous nerve. And we've always got to keep an eye on those deep circumflex vessels, as well as the bowel and the peritoneum with this block. So it's a planar block, so we can do this block with the patient asleep. And it's really nice for hip fractures. And just one more example of it now. This is using the butterfly probe. So we can see the internal oblique muscle here, the triangular muscle. In the middle is the fascia, and then we've got the sartorius muscle over to the right. Here you can see the deep circumflex vessels here as well. So needles coming in from the right side of the screen, so caudad. We're popping below both fascial layers. You just saw an extra pop there, and we'll insert our local, and you can see that zippering effect. Alrighty, so for the superinguinal fascia iliaca block, we're looking for that classic bow tie appearance of the internal oblique and the sartorius muscle with the thin fascial layers between. Always beware the complications. So beware the bowel perforation for this one. Beware the circumflex vessels in this one, and it's a high volume block. So we're looking at 30 to 40 mils, and it's great for hip fracture analgesia or hip fracture surgery. Alrighty, general nerve. This will be the last slide. So general tips and tricks for nerve blocks. So never inject if there's high pressure injection. So I always start every injection just with a gentle 1 or 2 mils. If you ever have high pressure, always stop. You know, so even a small amount of local anesthetic injected within the fascia can be game over for that nerve. So it's really important to make sure that you're not within the fascicle of the nerve. Always hold the syringe nose down is another tip. So if you've got air in the syringe, holding it, just let gravity do its thing, and just so you don't let any air into the field, particularly in your obese patients when you can have a little bit of difficulty getting a nice view. So always ensure that fluid, local anesthetic, goes in without any air. Always use a combination of visual and tactile feedback. You know, we've been doing tactile landmark technique for so long, so don't completely eradicate that from your repertoire. And also with the ultrasound probe, with the butterflies, we can use color Doppler as well. So everyone's anatomy is a little bit different. You know, we've got patients who've got varicose veins, they've got different vessel anatomy. And it's really important that we don't transect a vessel or an artery or a vein on the way to do a nerve block. So it takes 5 seconds. Just put color Doppler on. Try and appreciate if any vessels are going to interfere with your needle approach, and it just increases the safety of the nerve block.